So thank you very much, and good morning to everybody. I'm very, very pleased to be here speaking at this generics conference at a time which is extremely important for the Greek generic market and the generic environment. I'm from IMS, and IMS is present in well over 100 countries around the world and intimately involved with the pharmaceutical markets of all of them. So what I'm going to bring is an international perspective. We've already talked in some depth about some of the significant issues in the Greek market, and I know that that discussion will continue throughout the day. What I'd like to do is set that in the context of what we see happening in the world generics market, and also take a look forward, because there are significant changes in the nature of the generics industry itself and the generic opportunity in the next 5 to 10 years, and those will also affect the Greek generics market as it itself is changing. So I'm going to first start by taking a look at the world. I'm going to see where we see the growth as far as generics is concerned, and take a look at Greece in the context of other European countries. We're going to talk about the factors that are necessary for a robust generic market and where countries have managed to successfully apply those to achieve change quite rapidly, because often increasing levels of genericization has been a slow process in the past. Then I'm going to turn to the future of generics, and with that we'll encompass the question of biosimilars that is starting to be a trend and will be an increasingly important trend through to 2020. Let's start, however, with an extremely broad perspective. So what we have here is 65 countries that constitute the vast majority of the world pharmaceutical market. And what I've done is I've taken a look at the generics part of the market in green in terms of growth, and the whole of the market, pharmaceuticals plus generics. And we've looked at it in terms of volume here. The reason why we have done that is because then we strip out questions of list price and whether there is discounting below that to look at the real underlying demand for pharmaceuticals in what is called standard units, and that's the lowest therapeutic dose of any given agent. So practically speaking, for most of primary care, it's a pill. We can see that the growth of the generics market has been consistent in that it has outperformed the pharmaceutical market as a whole. And we're getting to the stage when these 65 countries, we have almost 1 trillion standard units in annual consumption of generics. And that equates at list price to about 180 billion US dollars worth of value. In fact, the real value will be lower than that because of discounting. The growth particularly took off in 2010 for the generics part of the market, driven by the fact that that was when the very first of the really big primary care patent expiries started with Cozar, Hyzar, and of course they have increased with Lipitor, Plavix, and many other products, and they will continue to. We do see a deceleration. It's still growth, but the growth has started to decelerate as it has for the pharmaceutical market as a whole. And that's simply a function of the fact that the global pharmaceutical market is decelerating at the moment because of financial difficulties, not only in the mature markets, but also in emerging markets. And recall that the growth we see in emerging markets, which is still very strong double-digit growth, is almost entirely driven by multi-source products, by generic products, and they still represent a very strong opportunity. So that's what we've seen in history in terms of demand. The demand for generics outpaces the demand for the innovative medicines in the market, driven by both opportunity, more genericizations, and necessity, the requirements of payers and governments to get a grip on their healthcare costs, which even before the financial crisis consistently outpaced GDP growth and wage growth. I'm going to move to take a look to the future now, and I'm going to change my perspective and talk about the top 8 mature markets, because IMS forecasts these markets forward to 2016. Top 8 mature is the lead 5 European markets of UK, Germany, France, Italy, Spain, plus the US and Canada, plus Japan. I'm also forecasting in value here, which is why this segment, the protected segment, is by far the largest segment, because it has by far the greatest unit value. But I'd like to draw your attention to the fact that the green part, which is the IMS-defined generics segment, increases significantly in size between 2011 and 2016, and its growth at CAGR in the 2012 to 2016 period of 8 to 11% is significantly higher than the growth of any other segment. In fact, we are seeing a decline in the protected segment because we have peak genericization, value is moving out, and it is not being replaced sufficiently by the new products that are launching into the market. We're at peak small molecule genericization now. The 2012-2013 period is when we see those very largest products go off. But between now and 2016, IMS estimates another 103 billion small molecule products will be at exposure to genericization. And the difference, I think, is going to be that those are going to be fairly evenly split in value terms between primary care small molecule products and specialist care small molecule products. And that will be a change. We will start to see products such as Gleevec, Novartis's small molecule oncologic, move off patent. So there will be a different element to the market. In addition, and we'll talk about this later, out to 2020, we see $67 billion worth of value in the biologics market exposed to the possibility of biosimilar competition. We'll talk about the degree to which that will be realized later. Let's move back to history. This is an existing picture of the year to September 2012, and I've done it in volume terms again to get a clearer picture of where the actual demand is. And what we've been able to do for a whole range of European countries, from Eastern European countries through to the Big Five, and indeed including Greece, is that we've split down the market, protected and unprotected, by the different elements of the market. So this light blue here is the protected segment in volume. Low volume, clearly substantially more important in value terms. This dark blue, which we've organized things by, is the no longer protected part of the market. And the greens and the reds are different types of generics, whether we have in the UK a significant part of the market that is INN unbranded, in other words, products that are simply provided as the generic name, Simvastatin, for example, or branded generics in green, or company branded generics. I think the point about this slide is to say that there is significant variation, even within Europe, in terms of the makeup of the market, in terms of the balance between the protected and no longer protected, but also within the generic parts of the market in terms of the type of generic that we are seeing. Absolutely, in the more robust generics markets that tend to be these ones here, clearly the proportion of no longer protected at the moment is relatively smaller. But the nature of what exists in the generic segment varies quite significantly. Countries have taken different routes to building more robust generic markets, and the factors that have been driving those have been also varied. If we take a look at some of the biggest markets, what we find is that the route to increasing genericization has historically been a slow one. So what we have done up the x-axis here is we've looked at the proportion of what could be genericized that is genericized, and we've looked at that in volume terms. So take each of these lines as a measure of the degree to which the part of the market that is unprotected is actually also generic. And clearly, the higher it is, the more efficient that market is at converting unprotected products to generic products. Unsurprisingly, the United States in green is at the top here. Japan is at the bottom. Japan has an extremely weak generic market. I would take two things from this slide. The first is you see the rate of change in general has been relatively slow. However, I would draw your attention to one country, which is the red country here, which is Spain. You will see there has been a significant uptick in the efficiency of genericization, which actually starts in 2010 and accelerates in 2011. And that is coincidental with the measures that the Spanish government took with respect to mandating INN prescribing and increasing the differential between the prices of innovative agents and generic agents and other measures. So change can be slow, but nevertheless, it is possible when we have the combination of necessity, the need to contain drug spills, and opportunity, the fact that we have more products in the market now than ever before that can have low-cost alternatives and therefore help manage healthcare costs. We talked about the routes that countries take to getting to a more effective generic market. And we've classified different countries, these are only a selection clearly, into those that are or were prescriber-centric, payer-centric, and pharmacist-centric. Traditionally, most countries were in that prescriber-centric box, where it was the prescriber that was the decision maker with respect to the products that got used. We had high-priced brand-led situations from the perspective of the patient, clearly a continuity of supply that was advantageous, but a high-cost approach to healthcare. Countries move away from that. Universally, we see that prescriber decision-making power over what gets used gets eroded. We've seen that with the legislative changes that have happened and the initiatives that are happening in Greece. We see, in terms of generic management, perhaps two approaches to this. It can be essentially a payer-centric approach to managing it, and I would characterize that as being, for example, as in Germany and parts of the US, where you see serial tenders for multi-source and low-cost products that manages price extremely well. For the patient, it can mean that they will not be receiving exactly the same product from prescription to prescription. One of the potential downsides of this particular approach to building the generics market can be where costs are driven so low that it is no longer economic for manufacturers to supply. And in the US, for example, we have seen situations where low-volume hospital products, but nevertheless essential to particular patients, have had breaks in their supply simply because the price has gone to a level where no manufacturer was actually willing to commit to manufacture. So there are downsides for healthcare providers on that side, as well as upsides. And also, some countries operate a mixture of being driven by payers, but also the pharmacist. When the pharmacist is put at the center of the decision about which product gets used and is motivated to dispense the lowest cost product. Moving out of a domestic market, generics manufacturers have to understand the decision makers and the motivations that the different decision makers have for prescribing, dispensing, and indeed buying generics. And these are varied across the major countries of the world. So if I turn to the question of what this environment that I've laid out means for generic companies, We are in a period of significant opportunity. Peak small molecule genericization, but it doesn't end in 2013. Beyond that, there continue to be opportunities not simply in primary care, but also in specialist care. Generics markets are still relatively underdeveloped in certain countries. They are also the key growth opportunity in the emerging markets. So there are a significant geographic opportunity that companies looking to grow outside of their home market have. And the question will be, where are the most promising countries, the countries which offer a volume opportunity as well as the prospect of an attractive return, and exactly how does that country work in terms of the decision-making criteria. But equally, companies increasingly have to think carefully about the therapy areas, the molecules, and the technologies that they make investment in. Why therapy areas? Because, as we'll see later in the presentation, the therapy areas that offer the most loss of exclusivity potential going forward include some which maybe have quite a different pattern of genericization to that we have seen in some of the traditional areas like cardiovascular. Also, we're seeing this move to specialist products, not just biologics, but also small molecule specialist products losing exclusivity. From a molecule perspective, companies that are seeking to expand have to make decisions about the molecules to invest in and ask the question where there is an opportunity that will not be eroded too rapidly in terms of margin enabling investment. And lastly, we believe increasingly a third segment of the pharmaceutical market will become much more defined, where a multi-source active is offered in either a device or a delivery system or with some other element that is unique and valuable wrapped around it. This is the part of the market that companies increasingly seek to develop because it avoids the loss of margin that the dash to commoditization inevitably generates. And all of these things need to be considered in the context of the structures and regulations, which, as you know, in Greece, change very, very fast over a short period of time. We'd like to take a look now at what we've seen as some of the factors for a robust generics medicines market. And I think that the point that I'd really like to emphasize is it is not simply a question of price. Payers tend to focus on price across the board, price cuts, whether it is in the generic segment or the innovative segment of the market. Medicine mix combined with price differentials is actually the key to reducing the costs of treatment in major therapy areas. I'll explain what I mean by that. We've done an analysis, I'll show you the results in the next slide, that takes a look at price per unit for products. It takes a look at mix for a range of therapy areas, and what I mean by mix is the mix between the protected products that are in that therapy area and the unprotected products that are in that therapy area, and also takes a look at the overall volume burden of that therapy area. And that is the equation that ultimately rolls up into the pharmaceutical costs that governments experience. The therapy areas we've looked at are a combination of primary care and specialist care areas, but they all possess the characteristic that they are a major cost burden to healthcare systems, and they contain a mix of generic and innovative agents. What we did is we worked out a cost per daily dose on average across these therapy areas, country by country, to say, what does it actually cost for a single daily therapeutic dose across these therapy areas in each of these countries, and how has it been changing? Here's our findings. What I'd like to do is make a few points here. Firstly, we're comparing like with like, similar products in the same therapy areas and we're comparing a measure of cost per treatment day here. I've included European countries, and I've also included a couple of emerging markets for comparison. What we find, here's the EU average, is that the cost to healthcare system at list price of therapies in these areas varies hugely, point number one. Also, whilst it has gone down, the fact of the matter is considerable variation remains. Greece was at 2012 Q3, which is when we made this last change, coming down. Obviously, we expect that that will continue to fall with the latest price cuts that have been announced. But the countries that have the lowest cost to the healthcare system per daily dose for these therapy areas, Denmark, for example, and the UK, are not countries necessarily that have a high, have a low price for innovative protected pharmaceuticals. For innovative protected pharmaceuticals, they tend to be high priced. The reason why they are down here and not up here is because although they have a segment of the market that is high priced and innovative, the larger part of the volume of treatment for these products is the low-cost generic sector. So we know that in Greece we have seen generic prices fall, but what that needs to be coupled with is a growth in the volume of the use of those generics in order to bring overall treatment costs down. That is the necessary next step in the equation to really building a robust generics market that actually achieves its goal of helping manage healthcare costs. If we take a look through what we see across countries in terms of drivers and constraints to building a robust market and encouraging generic utilization, many of these drivers are things that have been taken on board in Greece and are actively being applied. We shall start to see the fruits of this in the coming year. Mandatory prescribing by generic name, that's INN prescribing. Prescribing generics first and also choosing to dispense generics first. Increasingly across particularly primary care therapy areas, we have a situation where there are effective, good therapeutic alternatives that are generic, and then new agents. Effective generic markets are ones where doctors will prescribe a low-cost agent routinely first, and if patients cannot be managed on that, then they will move to the innovative agent. Again, it manages mix and makes the appropriate mix of the innovative high-priced products versus the generics. Managing patient incentives via reimbursement and co-payment levels and pharmacist incentives via dispensing management and oversight of doctors with respect to how they prescribe are also necessary drivers. Constraints. Weak generics markets can have cultural resistance from doctors. If there are lack of incentives for pharmacists to dispense, this will enable the reforms that have been put at the prescriber level to be scuppered. And if there is no margin for the distribution system in generics, that will also cause problems. And also a preference for brand, and indeed across-the-board price cuts, which don't recognize that there must be a differential between the cost of the innovative product and the cost of the generic product, will work against creating a truly effective generic market. I'd like to turn to the Spanish point. We already saw that Spain is unusual in the big markets that we looked at in terms of the generic efficiency, in that it had an inflection point. It suddenly started to become more efficient in converting off-patent segments of the market over to the generic. And it's really about a combination of initiatives and laws that happened over a 2-year period of time, starting with royal decrees in 2010 that brought about price reductions of generics, and particularly, and this is why this is highlighted, the Royal Decree in September 2011, and the point about mandating INN prescribing by the generic ingredient. In between then, there have been a range of other initiatives, not all of them focused on the generic market, but all of them focused around the very strong necessity that Spain has to manage its healthcare cost. But nevertheless, it is particularly those two levers that have led to a quite dramatic change in the degree to which genericization occurs once a product has lost exclusivity in Spain. So let me show you some data on that. What we have done here is we've taken products that have lost exclusivity in Spain in 2008, 2009, 10, 11, and 12, and looked at the average penetration in volume of the generics into the overall molecule over time. So this is the earliest one. This is 2008. And you can see that progressively over this period of time, erosion has become steeper and deeper. In other words, the measures that have been taken are starting to make the effect that is desired. We are getting to a situation where there can be an innovative segment, and that should achieve a price that encourages innovation, but the part of the market that has lost protection and should move to a lower cost generic situation is in fact doing so. Ultimately, it's all about a balance, and that balance needs to be tipped in favor of the drivers that are going to encourage a robust generic market. Absolutely about healthcare reforms that put in place the legislation, but about building incentives and making sure that there is also a plan for the future when the type of generic or the type of low-cost agent that is coming through will not be necessarily a small pill going into the primary care sector, but could be rather more complex in terms of offering. There are challenges. We are at peak small molecule genericization, although there is well over $100 billion worth of opportunity to go in the next 5 years. The big drugs have already lost exclusivity. Opportunities will become progressively smaller out to 2020 in the primary care part of the market. And the fact of the matter is this market itself is becoming more competitive as not only are the domestic players and the multinational generics companies, but big pharma and indeed agencies completely outside the pharmaceutical industry seeking to enter these areas. Delay in approvals. If the regulatory system does not allow generics to be approved and moved into the market rapidly, that is a fundamental issue both for the companies that want to invest in building a robust generics market and for the healthcare system as a whole. If the regulatory arm of government is not aligned with the rest of government, that will cause a major issue. And governments absolutely need to manage price, but they need to manage it in an effective and sensible way that encourages companies to invest in building generics opportunity in the generics industry, as well as preserving the opportunity for innovative products also to bring their value into the market. Lastly, I'd like to talk about the future of the generics market. Where will the growth come from, and what do we see that is new? Because ultimately the generics market is going to be quite different by 2016 and through to 2020 than we have traditionally experienced. It will be much less about primary care. It will be more about specialty and new types of low-cost offering. Here's a view globally of the top 20 products in the world as at the end of last year. It's quite a familiar picture, I think, to all of us, because we have seen Lipitor at the top of the tree for 10 years or more, and many of these other names are very, very familiar to us. The fact of the matter, though, is that this picture is going to change pretty fast because everything that I've ringed in red here is a small molecule product that either is off patent or will go off patent by 2016. Because they're small molecules, there will be no reason why they shouldn't very rapidly move out of this top 20 because they will lose value fast. The things that aren't ringed is not because they're not losing exclusivity. In many cases, they will be losing exclusivity in this period or up to 2020, but they all possess one characteristic, which is they're biologics. Mostly specialist biologics, but also, obviously, Lantus, which is a diabetes insulin product. So at the end of the next 5 years, the world's largest pharmaceutical products are going to look very biologic, very specialist, and very different to the situation that we see now. In addition, that is what payers will be most worried about in terms of the cost issues that they have to address for individual products. The things that they will be worrying about will be the biologics because the cost of many major small molecule products will have declined dramatically. They'll also be looking at the therapy areas that will realize savings going forward. So this is taking a look at the small molecule world for a second, and then we'll talk about the biologics in a moment. So small molecule patent expiries, the value of products facing loss of exclusivity globally by the different therapy areas, and we've also mapped it out by the date between 2012 to 2016. Respiratory is the largest area that will see loss of exclusivity. Respiratory is an area that will not genericize as a pill would because there is protection from the devices. But nevertheless, there will be pressure, and there are also already products that are essentially multi-source actives with a proprietary device that fit a sort of role between a full generic and an innovative agent. Antipsychotics and hypertension, but increasingly small molecule oncologics will be amongst the areas that are currently very high value and will see loss of exclusivity going forward. And then many of these other areas down here have already worked through their patent expiry cliff, whether it's anti-ulcerants, antidepressants, and so on and so forth. So it's not that they aren't important to generics, absolutely they are, but there is relatively little protected value still left to actually lose exclusivity. If we turn to the biologics market, here's another global view, which is top biologic therapy areas by global sales. And I've ringed 3 areas at the moment because these are the areas where we see at the moment in Europe biosimilars. So the erythropoietins, G-CSF, filgrastim, and up here, the growth hormone. The point is that very, very little of the global biologics market has actually been exposed to biosimilar competition as yet. And the real impact we will see in this market is when these parts start to be exposed to biosimilar competition. In other words, the anti-TNFs for autoimmune disease, the modern insulins, and also the monoclonal antibodies to treat oncology. So at the moment, this market is very nascent, and a lot has to happen if it's going to actually realize its opportunity. The question is, will it do that? Well, we think that there is absolutely an incredibly strong imperative on the part of payers and governments to ensure that a viable biosimilar market does develop, simply because it is such a large cost item. As we said, 12 biologics represent $67 billion of opportunity, and those are all ones that will be exposed to at least some form of loss of exclusivity up to 2020. These are the products which will be top of the list as far as payer worries are concerned as the Lipitor and the Plavixes of this world move out of their concern. So, will the biosimilars market become a major part of the market? Will it become a significant opportunity for generics companies and elsewhere? Well, we see two scenarios because there are so many things that are uncertain in this market. By 2020, on an upside scenario, the global biosimilars market could be $25 billion US. Now, clearly, that's substantial, but nevertheless only a fragment. In fact, it's only 10% of the entire global biologics market. For that to happen, the US needs to develop. There is no biosimilars market there at the moment. We need to see biosimilars establish well in these new areas, the monoclonal antibodies, and we'll probably start seeing those in Europe this year. We need to have further acceptance of these products, and we need to have companies that are actually able to realize a return on investment, on which is a much higher level of investment than you get if you're investing in bringing small molecule generics. If some of those things don't happen, and particularly if the US does not take off, the fact of the matter is this could be a much, much smaller part of the market. And on the other side, clearly, a much bigger problem of continued spend for governments. So this is an area we watch closely. It changes rapidly. It could be a significant change in low-cost multi-source offerings going forward. So I'd like to end just on 10 things to consider for generics, the things that we think will be the ongoing questions and challenges in the market. Clearly, combined with the move to a greater role for generics and managing costs within generics, particularly in certain country markets, there has been more commoditization, more movement to the lowest possible cost and unbranded offering. And this poses margin challenges. It's difficult for companies playing in these markets to invest if that happens too rapidly. And it may not be in the interests of governments to allow that to happen if they want to build and grow generic industry. We're at a peak in the market at the moment. There are still a great deal of small molecule genericization opportunities going forward, but it will start to progressively decline simply because the new small molecules that are being launched are fewer in number and they're smaller in overall sales than were the molecules of the 1990s and 2000s. Conversely, there's going to be more specialist small molecule opportunities. We believe that long-term generic company success is also going to be about moving up the value chain, making sure that you're exploring the opportunities not only to provide value for money, but also build value add where value add is appropriate and recognized, and developing this third segment between the protected sector and the multi-source sector in the market. However, this kind of incremental improvement in innovation will need a strong business case into today's payer environment because at the moment, price pressure, even at list price, on generics is down uniformly across countries. Countries absolutely wish to make sure that their domestic industries thrive and survive. An advantage for the home players, a challenge if you're seeking to move out into new markets, particularly emerging markets, where there is often a strong bias to the local players. More healthcare reform absolutely will seek to increase the efficiency of generic markets. Sometimes it is slow, but I think they will start to be more effective at understanding the levers that drive that. And this will go hand in hand with other measures that are designed to manage pharmaceutical cost, which could be around changing reimbursement, but also moving things off the reimbursement list. So we're in a time of great opportunity, but also challenges. I hope this has been useful. I'm happy very briefly to take any questions. No? Thank you.